Most psychological disorders are ego-dystonic. The person experiences their symptoms as foreign, distressing, and undesirable. Personality disorders are egocentric. The person typically does not experience their personality patterns as the problem, but rather sees other people and the world as the problem. This fundamental difference makes personality disorders among the most challenging to treat and the most disruptive to the people around the person who has them. Cluster A personality disorders are characterized by odd, eccentric thinking or behavior. Paranoid personality disorder involves pervasive distrust and suspicion of others, interpreting benign actions as malicious. Schizoid personality disorder involves a pattern of social detachment and restricted emotional expression. The person prefers solitary activities and appears indifferent to social relationships. Schizotypal personality disorder involves odd beliefs, magical thinking, perceptual distortions, and social anxiety, a milder form of psychosis without the full breaks from reality of schizophrenia. Cluster A disorders show genetic links to schizophrenia spectrum conditions. Cluster B personality disorders involve dramatic, emotional, and erratic behavior. Antisocial personality disorder is characterized by a persistent pattern of disregarding others' rights, deceitfulness, impulsivity, aggression, and lack of remorse. Borderline personality disorder involves extreme emotional instability, unstable self-image, impulsive behavior, self-harm, and intense fear of abandonment. Histrionic personality disorder involves excessive emotionality and attention-seeking. Narcissistic personality disorder involves grandiosity, need for admiration, and lack of empathy. Cluster B is the most clinically prominent and carries the highest associated morbidity. Cluster C personality disorders are characterized by anxious, fearful behavior patterns. Avoidant personality disorder involves a pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation, different from social anxiety disorder in its pervasive impact on self-concept and identity. Dependent personality disorder involves excessive need to be taken care of, submissive behavior, and inability to make independent decisions. Obsessive-compulsive personality disorder involves preoccupation with orderliness, perfectionism, and control that significantly impairs flexibility and efficiency, distinct from OCD, which involves specific obsessions and compulsions. Borderline personality disorder involves intense emotional dysregulation, rapid, extreme mood swings triggered by perceived rejection, abandonment, or interpersonal conflict. Characteristic features include a profound fear of abandonment, unstable and intense relationships that alternate between idealization and devaluation, chronic feelings of emptiness, identity disturbance, impulsive self-damaging behaviors, and recurrent suicidal behavior or self-harm. BPD is strongly associated with childhood trauma and attachment disruption. Dialectical behavior therapy, developed by Marcia Linehan herself, a BPD survivor, is the most empirically supported treatment. Antisocial personality disorder requires a persistent pattern since age 15 of violating others' rights through deceitfulness, impulsivity, aggression, and reckless disregard for others' safety, with no remorse for these actions. The DSM requires a history of conduct disorder before age 15. ASPD is associated with high rates of substance use disorder, incarceration, and domestic violence. Psychopathy, a construct measured by the Hare Psychopathy Checklist, captures a subset with additional features of callousness, shallow affect, and predatory manipulation. ASPD is far more common in men and in criminal populations. Dialectical behavior therapy, developed by Marcia Linehan specifically for borderline personality disorder, integrates cognitive behavioral techniques with mindfulness and radical acceptance, the dialectic of change and acceptance. DBT is delivered through individual therapy, skills training groups, phone coaching, and therapist consultation teams. The skills modules cover mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. Randomized controlled trials consistently show that DBT reduces self-harm, suicidal behavior, psychiatric hospitalization, and treatment dropout. It is now widely applied to other conditions including eating disorders, substance use disorders, and adolescent self-harm. Schema therapy, developed by Jeffrey Young, is a more comprehensive approach to personality disorders that targets the maladaptive early schemas formed in response to unmet childhood emotional needs, schemas like defectiveness, abandonment, and emotional deprivation. Schema therapy identifies and works with characteristic modes, emotional states, and coping patterns associated with different schemas, and addresses the therapeutic relationship as a primary vehicle for change through limited reparenting. Randomized trials show that schema therapy outperforms other treatments for borderline personality disorder and has been adapted for narcissistic, avoidant, and other personality disorders. The traditional view that personality disorders are untreatable and lifelong has been substantially revised by longitudinal research and clinical trial evidence. The collaborative longitudinal personality disorders study found that the majority of personality disorder patients experienced significant symptom reduction and even diagnostic remission over 10 years, particularly for cluster B disorders, including BPD. The symptom and functional improvement, while real, was not always matched by equivalent improvement in psychosocial functioning, highlighting that personality disorders require addressing both symptom and functional domains. Evidence-based treatments significantly accelerate natural recovery. Personality disorders represent some of the most challenging and consequential conditions in clinical psychology, not primarily for those who have them, but for the relationships and systems they move through. Understanding that these patterns arise from early adverse experiences, are ego-syntonic, and require specialized evidence-based treatments like DBT and schema therapy transforms the clinical approach from helplessness to engagement.